Okay, awesome. So, آخر session, I don't know if you guys all of you were there, but آخر مرة we talked about how to admit a patient. One of the things was you need to write an elaborate note on how to about the admission. Once you finish your note, but then the day-to-day progress notes start occurring. Progress notes are easy for you guys to take care of or to actually see the patients at that point. But one of the important steps in the progression in the story of a patient's hospital course is transferring. شو يعني transferring a patient? It just means sometimes patient will require either a higher level of care. For example, let's say somebody is on the floors, or they're having shortness of breath, they're admitted for pneumonia, and you're treating them for the pneumonia. But after some point, they are requiring a higher level of care, which means they're requiring either something that you can't offer on the floor, or they're requiring more kind of frequent checking. Okay, so when you're transferring a patient in general, it's most of the time you're going to be transferring up to a level. So it can either be transferring to a higher level, or you're transferring from the higher level to a lower level. What's important for you is to know both, how to do both of them, but transferring to a higher level, I think, is more kind of pertinent. I know both of them are very important for you to know how to transfer from a lower level to a higher level, okay? I won't go into details about what are the requirements or what are the indications to transfer somebody from a lower to a higher or a higher to a lower level. But I will go in details into how do you do that? How do you initiate and how to actually do that transition for patients, okay? When you finally, let's say, into your resident, you're attending, you decide this patient needs to go to the ICU, for example, and you need to transfer the patient from the floor to the ICU, okay? One of the simple things you might have in your mind, just place an order, transfer patient from floor to ICU, okay? That's perfect. But in order to achieve a seamless transition of care, which means until you're taking care of the patient, you're not just taking care of the pneumonia, you're taking care of the diabetes, the hypertension, the other things that the patient has. You need to make sure that the receiving team has information or knowledge about this, okay? And to make that transition seamless, you need to do two things, okay? You need to give verbal sign out to the receiving team. شو يعني sign out, by the way? We keep saying this word sign out. Sign out just means that you're signing off on your patient. You're telling the receiving team or the person who's going to be taking care of your patient important details about the patient that they will need, okay? But one of the important things is this has to be verbal. It can't just be written alone, okay? So it has to be verbal sign out of the transfer. And number two, there has to be a transfer note inserted into the system, okay? The transfer note will make sure that the receiving team has some written instructions or written confirmation about what's happening to the patient, okay? In terms of the verbal sign out, I'm not going to go into details about how do you give verbal sign out and what do you do with the verbal sign out. And at the end of the day, it's going to be your patient, you're taking care of them. So you're going to be the one kind of giving the verbal sign out. But I will focus on right now quickly about the transfer note that you need to write, okay? When you think about a transfer note, it's very similar to an admission note, but it's a little bit different, okay? So let's talk about the transfer note, okay? If you're writing a transfer note for a patient, you are the sender, okay? So the sender part, I'm gonna write here. So you are the person responsible for the patient right now, and you're sending them to another part of the hospital. Again, either a higher level of care or a lower level of care. It doesn't really matter, okay? I like to think of it as as a template in my mind, how to transfer the patient. And there are other people who will do it differently. Again, there is no one size fits all. It just depends on how you want to do it. You want to provide as much information as possible in as little, as little space as possible. And you don't want it to be a huge newsletter about the patient who just being transferred. Okay, so this is again, this is at least my template and what I've seen people do and what I have been doing. Okay, so we'll start one by one. The first part of it is going to be you're transferring the patient from which service to which service. Okay, so you're transferring the patient from floor to ICU, or you're transferring the patient from ICU to floor. Okay. Number two, there's going to be the reason for transfer. Okay, why are you transferring the patient to a higher level of care, or why are you transferring the patient to a lower level of care? Okay. Then after you put your reason, you really have to give a brief story about what's going on or what happened to the patient, what brought them to the floor in the first place, what brought them to the hospital, etc. So you really need to write the HPI again. Remember the HPI اللي كتبناه, the one we wrote in the admission note? It's going to be something very, very similar that you're going to put in your transfer notes. You're going to write an HPI that explains why the patient is there. Okay. And then more importantly, you're going to write a hospital course. This can be exchanged by saying floor course or ICU course, depending where the patient is. Okay. And so you're going to get the hospital course, how the patient, what happened to the patient, what did you do? You gave them antibiotics, you treated their sepsis, you gave them, you put on nasal flow, you did some CAT scans, imaging, they had an endoscopy, something. So you just give the course as a storytelling about what happened to the patient in the hospital while you're taking care of them. And then very important, people sometimes forget that. They think the hospital course includes this, but it doesn't. I like to include it as a separate heading. And this will be the significant event that led to the transfer. So this just means that what exactly happened, like for example, the patient suddenly became hypoxic, requiring more oxygen. We ended up doing a chest X-ray and we found a huge pneumothorax, blah, blah, blah. Okay, so it could be something like that. So the significant event is very important for you to describe. And sometimes you really need to describe in details at this point of hospital, like at 5:15 p.m., the nurse told me the patient did this, blah, 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 just like a little brief detail about what happened to the patient that led you to say, now we need to transfer the patient. Okay. And then after, so now think about it, and now you describe the course of the patient من لما فات على الhospital حتى before that all the way until that significant event, and now you need to transfer them. So now kind of your job is done in terms of telling the story. So now what you can do is just relist the patient's past medical history, relist the patient's family history, social history, all that stuff that you usually list in your admission note. The social, like kind of peripheral history about the patient, just to give more idea about what's happening with this patient. And then very important is for you to also mention, after you finish telling the story, what current meds is the patient on right now. Okay, so what medications are you treating the patient with right now? Sorry. And this is going to be like all the antibiotics you have them on, all the, whatever home medications you have them, just like a list, like a laundry list of all the medications that the patient is currently on. And then once you finish kind of telling the story, think about it. This current meds is similar لما تحكي home medications while you're admitting a patient. This is not going to be home medications. This is going to be current medications that the patient is currently on. And then you're going to write a physical exam. And this physical exam is going to be the physical exam upon transfer, essentially. So once you transferred the patient, what was the last physical exam that you saw them on? Obviously, you're going to write your vital signs plus the physical exam. complete physical exam. And this is very important. A lot of the times there will be a physical exam on the transfer, and then once the patient reaches, for example, the ICU, the ICU nurse notices that the patient has a droop, for a facial droop, and then you look at the physical exam and you see that this facial droop wasn't present on the transfer exam like 10 minutes ago. So things change, especially with patients who are acutely ill like that, transferring from floor to ICU. So you really have to document your physical exam at the point of transfer when you initiated the transfer. Then what you can add is some ancillary data, which means you want to add pertinent labs, pertinent imaging, pertinent procedures that the patient underwent. These things are very important. Micro, any cultures that are pending, cultures that came back. Again, it's very important to reiterate that in your note so that the receiving team doesn't have to dig throughout the chart, and they receive a patient with a complete transfer note that has all the information needed, okay? And then the most important part of the transfer note, in my opinion, is the assessment plus plan of the patient. And this usually goes, point by point. Just like when you wrote your admission note, you went point by point, you went, problem by problem. Pneumonia, this is what we do. GI bleed, this is what we're doing. Chronic medical problems, this is what we're doing. All that things, okay? So again, just to review it quickly, the things you have to work on is first to say the patient is being transferred, from place to another place, from like floor to ICU. And then you're going to have to write the reason for the transfer, why the patient is being transferred. And the reason I put these in yellow is because these are things you have to come up with. They're not written for you, okay? While HPI, as you imagined, it's something that's already written, right? It's very easy for you to just kind of copy paste or use a predetermined HPI that you already have, especially if the patient was admitted yesterday or 2 days ago. You have kind of a written HPI, okay? Hospital course is going to be a mixture, right? It's going to be a mixture of something already happened and it's easy for you to copy paste, and something that you have to kind of dictate. You have to write and you have to come up with. That's why it's kind of half green, half yellow in my mind. It's half written for you and half something you have to write. This significant event that leads to the transfer, this is all you. You have to come up with why the patient is being transferred. What was that significant event? Okay. Then you got, family history, surgical history, current medications. These are very easy. In fact, like if you're using Epic, for example, these are pre-populated. You can just pre-populate these. These will be something like, dot medications or something. It's like a phrase. You dot something, it like pulls up things. Okay. And then, one of the most important things to write is this is not going to be a copy paste. This is going to be your own physical exam. It's very important for you to write and document that physical exam that you're transferring the patient on. And then finally, labs, imaging are, you just pull them out from the chart, easy. And then again, the most important part and the most kind of tough part for you to write is this plan or assessment and plan point by point. Okay. And, if you want to look at it from in terms of more importance, I think this is probably the most important part is your assessment and plan about what are you doing for the patient? What do you suggest the receiving team to do for the patient? Okay, so this is going to be your full documentation about exactly like how to transfer the patient. And let's say you're on the receiving end, right? So you receive the patient and you have this like beautiful transfer note that you wrote. Now what do you do as the receiving part of the patient? So once the patient gets to the to the other side of wherever they're going, then you got the receiver, right? So you as the receiver, what you need to do is also document that you received the patient. It can be extensive, but it doesn't have to be, okay? What it has to say, it has to mention that you received the patient, you saw the patient, and you physically examined the patient, and you either agree or disagree with this assessment and plan that was brought to you from the transferring. Okay, so what you can do is usually, just to be technical, until you receive a note that's already written, what you do is you either addend the note. Addendum just means you add something to the end of a note that's already been written and signed. Okay, you either addend the note that was already written, or you write new notes, that I received the patient. And what you say is you want to say, number one, that you received the patient, right? And then number two, you're going to write your physical exam, including the vitals. And number three, you want to write, I agree, with the assessment and plan that is outlined here. Or you disagree and you want to change things. Like, let's say you notice that the patient has the facial droop, and now you notice this is a new thing on your exam. So you have to add it as a new problem and deal with it as a new thing, as like a stroke or something. Okay. Or add new problems. And usually what happens is after you do that, you probably have to kind of go over the patient's orders and modify or continue some of the medications, because what happens is when there's a transition of care, all the medications are popped out to you, and then you can either continue or discontinue some or all of them. And that all depends on your assessment and plan. What do you think is going on? Obviously, you can do this overnight, but at the end of the day, you're going to have to staff with your resident, with your attending, and then that's going to be the final plan of how to transfer the patient and receive the patient. Questions about this? You guys okay with it?
Yeah, it was good. Thank you.
Okay, cool. I'm just going to talk briefly then just about, now that you transfer the patient, you know how to admit a patient, you know how to transfer a patient. It's very important for you to know how to discharge a patient. Okay, so how do you discharge patients? The first thing you have to think about before you discharge somebody from the hospital or release them from the hospital is, number one, are they ready for discharge? What do you think? How do you know how to determine like how a patient is ready for discharge? Like, give me an idea. What do you think would be like a reasonable question to ask?
Like, if the patient did meet the assessment and plan.
Okay, so if they met all your plan endpoints, that is no longer short of breath or something like that, that's excellent. Yeah, that's very objective. But I'll tell you what, it's very difficult sometimes to know, because a lot of times patients will come to the hospital at this level of, but well, they were like normal, then they got sick, and then once they're ready for discharge, they won't go back to their normal baseline. They might be a little bit lower, so it would be difficult for you to kind of know. Usually it's kind of a weird question, but what you want to ask yourself is, if I discharge this patient right now, okay, are they gonna come back? That's gonna be your question. And usually, are they gonna come back within 30 days? That's kind of the more objective question that you want to ask yourself. Is that, yeah, they're having some shortness of breath, but if I discharge them, they probably will deal with it for a little bit and then probably get better slowly. They won't come back, okay? But if you feel like as soon as you discharge them, they're gonna bounce back, that's bad, right? And the other thing is that once you discharge them, for them not to come back within 30 days, you have to make sure that they have enough medications, they have all the follow-ups, everything that's needed for them not to come back, okay? So that's the first question, is are they ready? Then you ask yourself, if I send them out now, are they gonna come back? If the answer is no, they're not, then they're ready and you're good to go, okay? Question number two you have to ask yourself is, where do you discharge the patient? So where to discharge these patients? Again, we're not used to it. We're not used to where to discharge a patient. We're usually used to, we discharge these patients to home. and that's it. Family takes care of them, no problem, right? But you have many options here. When you come here and you start your residency, you'll have many options about where to transfer, to where to send those patients. And option number one is home, okay? So you can just send them home, okay? Option number two, you can send them home, plus they get what we call health services. What does health services mean? It means that you schedule them, some companies that are responsible to take care of patients, where they send nurses, visiting nurses, to the patient's house, okay? And the nurse is able to draw blood, is able to give IV medications, is able to measure blood pressure, measure weights, a lot of things, okay? So if you think that the patient needs some sort of services, you can send them home with these health services, okay? And you really have to determine what services. And to determine what services, you have to either make a decision yourself, or if you remember our friends from PTOT, the physical therapist, occupational therapist, they will guide you. They will guide you whether the patient is okay to just go home, or they probably need some sort of services before they go home, or they go home with some sort of services. Okay, so I can do IV, blood work, etc. Okay. Another thing that you need to know when you're sending out patients is that there are levels of, like, if you're not sending them home, then you're sending them either to a nursing home, or you're sending them to what we call a rehab, or you're sending them to what we call an LTAC. And I'll tell you what these are, okay? So first you can send them to a nursing home, okay? Or sometimes it's called skilled nursing facility, SNF, okay? And the other name for it is long-term rehab, okay? These are people who live the nursing home, essentially. It's like, oh wow, the meeting is about to end in 10 minutes. They live in like a nursing home for kind of more or less a prolonged period of time, but not too long, okay? Maybe 2-3 months, and then they go home. He's slowly recovering. They have all the services, they can draw blood, all that stuff, okay? The other thing can be something called short-term rehab. So short-term rehab just means that these patients will require some sort of active, everyday physical therapy, okay? So this is mainly like, it indicates that the patient needs PT daily physical therapy. And usually these short-term rehab centers are inside, they are inside a long-term rehab center. They're like a section, like a few rooms, a few section suites that is a short-term rehab. Okay, which means they need some blood work, more blood work, they need daily checkups, they have a doctor who comes and visits them and takes care of them, okay? And then finally, where patients can go is something called a long-term acute care hospital. Again, think this is hospital, this is called LTAC. Okay, so this is a real hospital. That's usually who ends up there are people who are unable to wean from the vent, for example. They end up with a trach, they end up with a peg tube, a gastrostomy tube to get feeding. They're just like a prolonged hospital course, and they can't really go to a short-term or a SNF. So they end up in these long-term acute care hospitals. So think of these as people who are vent, trach, plus peg people. They end up in these kind of hospitals. Okay. And why do you care? And as you're discharging the patient, why do you care? You care because what's important for you is while you're discharging, you need to write a destination. Where is the patient going to? You need to tell the ambulance or whatever, whoever's taking the patient, is they're going to there. They're going to a long-term rehab. They're going to a SNF. They're going to short-term rehab. Another thing that's important for you is because you are the physician taking care of them, you have to do some paperwork we'll talk about next, and you have to prescribe them medications. What's important for you to know in the people who go home or home with services, you need to prescribe all meds. All their meds, you need to prescribe them again. You need to give them the antibiotics. You need to give them the antihypertensive. You started any new medication in the hospital, you need to give it to them. You need to prescribe it, either send it to their pharmacy or like write a script and then give it to them. While these people who go to a nursing home or short-term or long-term rehab, you don't need to prescribe all their medications. You only need to prescribe what we call Schedule 1 drugs. Schedule 1 drugs means something like opiates, narcotics, benzos. These are medications that you can't just send the patient without, but they need a doctor to prescribe these medications. And what happens is that a doctor usually sees those patients in the nursing home within 24 to 48 hours. So you really want to give them a 2-day course of whatever. Like, let's say you had somebody on some sort of benzodiazepine, or you have somebody on morphine, like prolonged morphine for pain management. You can't just send them to a sniff without morphine. You need to give them at least a 2-day course of morphine. You should write it as a script, and then their doctor, after 48 hours, then whoever is taking care of them there will start being responsible. Okay, so these are things kind of keep in mind, things to remember when you're discharging these people. All right. The meeting is gonna finish in 5 minutes. Can we hang up and rejoin, guys?
I don't think we have to, because I'm usually Zoom gives you a 15-minute warning.
Really?
However,
Okay.
it usually, yeah, it usually stays for 1 hour before it kicks us, not 45 minutes.
Perfect.
So yeah, I think we have like 15
Let's
more
keep going.
minutes
Okay,
to go.
let's keep going. Perfect. So after you kind of figured out all these things, number 3 would be the paperwork. The worst part is the paperwork. Okay, or like I like to call it, it's really computer work nowadays, unless I don't know which hospital still use paper, but it's really computer work. Okay, so just to go quickly, like kind of step by step, how are you gonna get how are you gonna get this patient safely out of the hospital? Okay, I'll just write the steps and I'll tell you one by one. So the first step to do is, you're ready for discharge. You started, you changed, you did some sort of medications. First thing you do, you do something called reconcile medication. So you want to reconcile their medications, and then you want to prescribe new medications. So you want to reconcile, which means you want to see any changes that you did to their home medications. Let's say you lowered their amlodipine, you started them on aspirin, you want to prescribe it. So you really want to figure it out, how to discharge them with all these medications. Okay, that's number 1. Number 2, you have to make appointments. And it just means that you need to either make sure that they have follow-up appointments with the people they have to follow up with. Like, for example, somebody just had a GI bleed. You have to make sure they have a GI appointment. How do you do that? It differs from hospital to hospital. You might need to do some phone calls. You might need to send some emails. Whatever you do, just make sure they have some sort of appointments. Okay. Sometimes the fellows or the consultant will let you know, hey, they have an appointment this time. Okay. And so after you do these 2 things, so now kind of you're good to go, right? You gave them the meds, you made sure they have appointments. You need to tell them about it. You need to tell the patient that you have these sort of appointments. So you have to give them what we call instructions. So you have to give them discharge instructions. And these discharge instructions are going to be, either in layman terms, like, dear Mr. So-and-so, you were admitted to the hospital because of this. We did this to you. We're discharging you with this. These are the changes to your medications. These are your appointments you need to follow up. Okay. And you give them kind of word by word. It's time consuming. Some systems are better than others, but it's a little time consuming to do that. But it's very important, again, because you don't want them to bounce back in 30 days. You want them to just keep following up and not come back to the hospital. Okay. And then you're going to write something called a discharge summary. So how is this different from a discharge instructions? A discharge summary is exactly the same as a transfer note. Remember the transfer note we wrote is exactly kind of the same as that transfer note. The only difference is that you're not transferring from hospital to ICU. You're transferring from hospital to home. Okay, so it's kind of, you're writing the whole hospital course, whatever happened to the patient, and then what are you discharging them with? Okay, and then we'll talk a little about it. And then an extra step that will go a long way if you do it is you need to, discuss this discharge plan discuss the discharge plan with the nurse plus the social worker. The social worker is ultimately the one responsible to kind of call in the ambulance, get the patient out of the hospital eventually, or get them to the nursing home. Okay, so you have to kind of discuss the plan with the nurse, social work, book the ambulance. They usually do that. Okay, and then finally, the easiest part is you have to place a discharge order in the system, in the electronic medical record, in the EMR. And that will kind of end the deal for you. You discharge the patient, all is good. Okay. Just to give you an idea about this reconciliation. So reconcile meds or prescribe. What happens is usually you will have a list of medications, like let's say aspirin, 81 milligrams. Then you have, I don't know, Lopressor, 12.5 milligrams BID. And then let's say you give the patient ceftriaxone 1 gram IV daily while they're in the hospital. And let's say they have amlodipine at home. Okay, they take 5 milligrams. So what ends up happening is that you have like, let's say this is a home medication and this is a home medication, this is a house, okay? And this wasn't a home medication, but the home medication is Toprol XL, 25 milligrams daily. This is the home medication. So, and you, while in the hospital, remember we switched them from the long-acting metoprolol to the short-acting BID, okay? So you will have 3 options in your, okay? So it's gonna be either continue the same medication, or discontinue, okay? Or prescribe, or like change, prescribe or new prescription, okay? So what's gonna happen is that you're gonna kind of tick the box, like, okay, aspirin, I'm gonna continue. Okay, Lopressor BID, I'm gonna discontinue. All right, ceftriaxone IV, it's out of you're not gonna send somebody with IV medication. Okay, then you're gonna continue amlodipine, but the doctor is like he's not always there. So he comes, essentially he shows up every day or every other day. And this is what the reason he shows up every other day, because he's only legally responsible to see the patients within 48 hours of their admission. So he gets notified that a patient got admitted today, a patient got admitted yesterday. So he's like, okay, I'll show up today, I'll see both patients, and then he leaves. So when he shows up, then he can see, oh, this patient needs pain meds, and the nurse is gonna notify them that, you know, that patient needs pain meds. Okay, and then he will prescribe it.
And prescription for narcotics and whatever class 1 drugs is gonna be for only a couple of days until the physician arrives, and they'll take care of it later on.
Exactly.
All right. Thank you.
Now they might want to change, you know, they might want to change. It's up to them. At the end of the day, they're the doctors now, so they can change the plan, they can change the assessment. It's up to them. They can see your assessment and plan, and they have your discharge summary, but they might change like what they want to give the patients. So it's not like 100% that the patient will get what you give them. Okay. So we got to this point where we're like discontinuing prescriptions, but like, let me ask you a question. Like, for example, this patient in this example, we reconcile their meds, we're continuing the aspirin, amlodipine, and Toprol, and we're discontinuing the Lopressor and ceftriaxone. Do you notice something missing here? What do you think? I'll tell you what's missing. What's missing is the antibiotics, because you know, you prescribed this. This patient was in the hospital on ceftriaxone, but now you're discharging them without any antibiotic. You can assume maybe they finished the course of antibiotics. A lot of the time, that's not going to be the case. What's going to be the case is that they still need more antibiotics. Okay, so what you end up doing is you want to prescribe them, you know, a new medication, and you know, you can prescribe them, like, let's say you prescribe them cefpodoxime. to take, whatever, 500 BID. And then this is going to be kind of a new prescription at this point. So this will be sent to their pharmacy to be taken. Okay. The other thing, you can always change their meds as well. Like, for example, you can say, hey, your amlodipine is now 2.5 milligrams because you don't need it. So you can change, you can modify these things. It's just you really need to do all these things, and then you need to sign and then send to the pharmacy. Okay. We talked about making appointments. So then you have to make appointments and call and to make sure that they have all the appointments. And then in terms of like the DC, the discharge instructions, sometimes it's called discharge referral because it has all the referrals of the patient. This essentially will be in layman terms. So this is in layman terms. So don't write to the patient, you had a CVA of the MCA M1 branch and we did TPA with whatever, like put in a lot of like medical jargon they won't understand. Instead, what you need to do is to write it in the most dialed down, like an 8th grader, you know, like can understand it. Okay, so you need to be like, hey, you had a stroke, or sometimes called the brain attack, to the part of your brain that controls the left side of the body, something like that. Okay, so you have to really dial it down for them to understand and then have an idea. And then when they go see their doctors, they know what they're talking about. A lot of patients I see in my clinic, they have no idea what's going on. Their doctors never told them in layman term. And then, you know, patient will say yes to whatever you say. They're not like, as a patient, even me as a patient, you as a patient, you're going to say yes, even if you don't understand, because you're trying to act like you're not stupid. So you really have to be, you know, very nice and write things in layman terms for the patients. What you can also add to this is to write some sort of template instructions. And these template instructions can either be found on the EMR, so on the EMR, or you can find them on UpToDate. So on UpToDate, actually, when you open any, like, let's say you admitted somebody for like CHF exacerbation. If you go to UpToDate CHF, you will find at the end something called instructions for patients. And it has two parts. One is basic and one is beyond the basic. Basic just means that somebody, you just want to give them basic instructions. You don't want anything else. Sometimes some patients are more involved in their care. They know the name of meds. They know a lot of things, especially the younger ones. Then you can give them the other one, this beyond the basics. This goes into a little bit more details. It's already written down for you. So it's very nice. And I encourage you to use it once you start using these things. Okay. And then, you know, finally, you or your resident, whoever, gonna write the discharge summary. Okay. And again, the discharge summary, there's no right or wrong in writing it, but some things you need to know about this discharge summary. So the discharge summary has a deadline. Okay, you have to write the discharge summary within 24 hours. Okay, within 24 hours of discharge. Okay, it has to be written down. Okay, except if the patient is going to a nursing facility. If nursing is going to short-term rehab, if patient is going to an LTAC, okay? If any of these exist, then you have to write it prior to discharge. There has to be a discharge summary, or else the accepting facility are gonna say, we're not gonna accept the patient because we don't know what happened to him in your hospital. We have to have a discharge summary. So how do you tell them what happened in your hospital? Okay, so this is kind of a quick note by note how to write a discharge summary. So number one, you're gonna write the discharge dates. Okay, easy. Number two, you're gonna say discharge to whatever, skilled nursing facility, whatever. Okay. Number three, you're gonna write the HPI like we did with the transfer note. Number four, you're gonna write the hospital course. Okay, and this can be either a paragraph or can be problem by problem. Okay, so I usually like to do it problem by problem. And what's the most important part of the problem by problem? This, you have to write down like very honestly and very explicitly changes in medications. Why is this important? This is important because once you, like, for example, let's go back to our example here. We changed the amlodipine right here. We changed the amlodipine from like 5 milligrams to 2.5 milligrams. You have to write down explicitly in your discharge summary why you did that. The reason is because once they are out and they see their primary care physician, the primary care physician, they're not gonna go back and read your progress note every day, what happened, and like a hospital course. All they're gonna do is they're gonna read the discharge summary, see what happened to the patient. If they see no reason to change the amlodipine in your discharge summary and it was changed, they're gonna assume it was changed by mistake and they're gonna get it back. So I think this is kind of very, very important to highlight the changes in medications that you did, okay? And then finally, you're gonna write, a few things. You're gonna write something called primary diagnosis, which is what is the primary diagnosis that the patient was diagnosed with, and then you're gonna write the secondary diagnosis. And then sometimes some discharge summaries include an initial diagnosis if it's different from the primary diagnosis. Like, let's say you diagnose somebody with pneumonia once they came in, but then you were like, yeah, you know what, this is CHF exacerbation. So your primary diagnosis becomes a CHF exacerbation, okay? And all these are gonna be in ICD-10 codes. These codes either will be embedded in your system, in the EMR, or you can just Google them and then find the ICD code appropriate for like pneumonia or whatever. The more narrow you are with the ICD code, the better. Like, let's say somebody came in, CHF exacerbation. CHF exacerbation is too wide, it's too broad. What they want acute on chronic heart failure with reduced ejection fraction, for example. That's like a code. So that would be the primary diagnosis, okay? And then, finally, you want to write any procedures that the patient underwent specifically, like endoscopy, LP, whatever procedures. And then you're going to write the consults that the patient received. Got a GI consult, heme consult, surgery consult, whatever people you consulted, okay? And that's kind of pretty much it in terms of the discharge summary. If you have all these in place, I think the receiving facility or the receiving people who will receive the patient will be able to continue, okay? Especially if you did all your work in terms of prescribing them the medications they need and all that stuff. You guys have any questions about these things? All right, cool. I think this is kind of more or less of a short session, but I'm glad we got it over with, because I think it's very important. By the way, I'm gonna share these writings with you. I'll share the transfer, I'll share this one, and then I'll upload this as a video for everybody else to watch. All right, awesome. Take care, guys. Have a good night. Sorry for the late session.
Thank you. Have a good day.
Thanks, man. Bye-bye.